Most of the challenges that have reshaped family therapy in recent years, including the feminist critique, postmodern skepticism, and social constructionism, have been in reaction to the field's early mechanistic concepts and aggressive attitudes. These recent movements have raised new questions about the therapist's style of leadership and have renewed interest in collaborating with rather than confronting or directing families. Basically, there's been a shift from systems thinking toward focusing on family dynamics. The boundaries between the discrete schools within the field have eroded. Today, it's pretty uncommon to encounter a family therapist who describes themselves as purely structural or behavioral or strategic. Today, therapists sample ideas from different schools and from outside the field. Some of this shift is attributable to the death or retirement of the charismatic pioneers of the various schools, some to a growing emphasis on integrating across models, and some to efforts to tailor therapy to the specific needs of certain client groups. Postmodern psychology concerns itself with how people make meaning or construct reality in their lives. According to the postmodern view, there's no objective reality, only different points of view. As a result of postmodern skepticism and relativism, family therapists are more humble and have renounced their status as experts relative to clients. Also, researchers, clinicians, and theorists spend a lot more time today focusing on a variety of family forms that are influenced by different ethnicities, race, social class, and sexual orientations. And today there is also a big focus on the application of family therapy to special populations and specific client problems. The central premise of the feminist critique is that marriage and family life have subjugated women. In 1978, Dr. Rachel Hare Mustin wrote an article about feminist family therapy that advocated for a style of therapy that called systems therapy into question and exposed the gender biases in existing models. For example, the idea of circular feedback loops. If all parts of a system are equally involved in its problems, no one is to blame. This idea was critiqued because it colludes with patriarchal rules by suggesting that husbands and wives have contributed equally to and share equal responsibility for changing their problems. To feminists, the idea of equal responsibility for problems looks a lot like blaming the victim and rationalizing the status quo. So this criticism was particularly relevant as it relates to crimes against women, such as rape or battering, where theories imply that women provoke their own abuse. While most family therapists these days are sensitive to issues of gender and gender inequality, your text suggests that the term feminist family therapy should be reserved for approaches that make gender equality the primary focus of treatment. Feminist family therapists may practice within a variety of specific models. For example, Betty Carter was a Bohemian, and Deborah Lupnitz is an object relations therapist. They share a focus on conditions that make life unfair for women. Social expectations, like the cultural standards of physical beauty that influence men and women, the role of unequal earning power on the politics of the family and empowerment of men and women, and they stress the difference between power to versus power over. Constructivism suggests that reality doesn't exist as an objective fact, but instead as a mental creation of the observer. How therapists see families is a product of their particular set of assumptions. Constructivism requires greater tentativeness about the validity of one's observations and a closer examination of the assumptions one brings to encounters with families. Social constructionism is a variant of constructionism that emphasizes the power of social interaction in generating meaning for people. According to its main proponent, Kenneth Gergen, the realities we construct are anchored in the language, systems, and social context in which we exist. The narrative metaphor focuses on understanding how experience creates expectation, and how expectations then shape experience through the creation of stories. Narrative constructivist therapists consider the self a socially constructed phenomenon. A person's sense of self is thought to emerge when interpersonal conversations are internalized as inner conversations. These conversations are then organized into stories by which we understand our experience. The question isn't one of truth, but which points of view are useful and which lead to positive change for the client. Narrative therapy becomes a process of helping people re-examine the stories they live by. The postmodern sensitivity movement was fostered by increasing exposure to a variety of cultures. Different family structures are no longer viewed as problematic simply because they don't match the American middle-class norm. Monica McGoldrick, the author of Your Genogram book, and her colleagues were among the first to sensitize the field to the importance of being knowledgeable about various ethnic groups. Family therapists today are much more likely to consider and explore the ethnic heritage of a family. As the ethnic composition of the U.S. continues to evolve, therapists will likely work with more and more diverse families. These changes will require a greater understanding of the impact of overt and subtle racism in our clients' and colleagues' lives, as well as require each of us to confront our culture's racial stereotypes. The task of therapists working with families of various backgrounds is to understand their symptoms, reluctance to engage in therapy, and distance or hostility in the context of their environment and their history of negative interactions with white institutions. Many therapists have a limited appreciation for the obstacles poor clients face or the devastating psychological impact of poverty. Therapists must educate themselves to the political and social realities of being poor in the U.S. The economy contains built-in disparities that make it difficult for anyone to climb out of poverty and keeps 1 in 4 children in poverty. Few therapists understand how crime and violent behavior of poor youth is related to the culture of trauma and abuse that pervade their childhoods. Gay and lesbian families are now considered to be one of many diverse family types. To effectively treat same-sex couples, therapists must be knowledgeable both about their own biases and about the lesbian and gay world. They have to examine their attitudes about sexuality, their unexamined prejudices regarding gay parenting, and try to understand issues of homophobia and heterosexism. Breakthroughs in the technology of studying brain functioning using fMRIs, PET scans, ERPs, and TMS have produced a growing body of evidence that our brains are programmed in childhood to respond to certain situations in an emotionally reactive way. This is why we keep doing things we shouldn't and don't stop doing things we should. Emotion, not cognition, is the primary organizer of the human experience. Thinking counts, but not nearly as much as we might have originally thought. Although the emerging neuroscientific advances suggest that our brains are wired to respond in certain ways, this doesn't mean that we have no control over our behavior. Nichols suggests not confusing neuroscientific responses as causal determinants of behavior. Throughout the 20th century, counselors didn't bring religion into session. In the 21st century, however, as increasing numbers of people find modern life isolating and empty, spirituality and religion are emerging as antidotes to widespread feelings of alienation. In turn, family therapists have begun writing about spirituality, emphasizing the use of spiritual practice to keep one's heart open, to bring compassion, acceptance, and love to clients. Family and couples counselors who are spiritually sensitive recognize that people need to feel connected, not only to their partners and children, but also to something greater that gives meaning to their lives. Few themes are more important in contemporary family therapy than designing specific treatment approaches for specific problems and populations. A number of books have emerged that focus on how to treat families with a host of specific types of problems and family constellations. For example, treatment of families with individuals with schizophrenia, bipolar disorder, people who are addicted to substances, abuse of food, each other, treating single-parent families, divorcing families, step families, etc. Many of these books transcend a particular theoretical orientation, and they focus on the specific needs of various types of clients. Your text offers treatment guidelines for working with single-parent families, African American families, and gay and lesbian families. Some understanding of the dynamics and special burdens of each of these groups is necessary for effective treatment. With single-parent families, for example, finding additional support, both personal and financial, for the custodial parent. This is often a prerequisite to helping the parent make constructive changes in their parenting or their social life. With African American families, it's often important to help activate the resources of an extended kinship system in order to support a family. Therapists are encouraged not to ignore fathers when working with the African American population. In working with gay and lesbian families, therapists are advised to be aware of homophobia, both in their clients and themselves, and to respect the dignity of same-sex relationships. Your text describes problems associated with sex and the internet, especially adolescent experimentation and potential victimization by adult sexual predators. On page 201 in your book, there are some suggestions for protecting kids from cybersex predators. Home-based work helps families use their own resources as well as various community resources, as opposed to traditional family therapy that focuses on repairing family dysfunction. The four central components of home-based services are family support services, therapeutic intervention, case management, and crisis intervention. Home-based workers are advised to set reasonable expectations and to clarify roles in order to maintain professional boundaries and avoid letting their contacts become merely social. Because outreach workers have to coordinate their efforts with a variety of other agencies, it's important to treat other providers as potential partners in the treatment process, not as adversaries. Carol Anderson and her colleagues have focused their interests primarily on the impact of schizophrenia on families. Schizophrenia is viewed as a thought disorder involving a biological vulnerability of unknown origin that makes people highly reactive to stress in their environment. Anderson's message to families is that they're not responsible for the patient's illness. Psychoeducational treatment works to provide information about schizophrenia and empathy and support for the family's struggle with the illness. Psychoeducational therapists discuss with families the empirical findings on expressed emotion and teach them how to reorganize to minimize the levels of stress in the family. Families are encouraged to provide an atmosphere of low stimulation and to lower their expectations of the patient while maintaining structure and firm limits. Psychoeducational therapists discuss with families the empirical findings on expressed emotion and teach them how to reorganize to minimize the levels of stress in the family. Families are encouraged to provide an atmosphere of low stimulation and to lower their expectations of the patient while maintaining structure and firm limits. The psychoeducational model is useful for treating any chronic problem, including depression and alcoholism. With respect to goals for treatment, this model demonstrates a shift in focus away from cure and toward coping. Medical family therapists work with families struggling with chronic illnesses or disability. They work in collaboration with pediatricians, family practitioners, rehabilitation specialists, and nurses, and they're supported by a growing body of research showing that family therapy has a positive effect on physical health and healthcare usage. Medical family therapists suggest that as soon as a patient is diagnosed, the family should receive a psychological consultation as a preventative measure to explore their resources relative to the demands of whatever their illness is. Relationship enrichment programs offer couples guidance in making relationships work, which can be used to address or prevent problems and offer an alternative to therapy. Among the programs described in the text are marriage encounter weekends and the prevention and relationship enhancement program. Your text also describes some of the skills that are thought to help make relationships work, which include accommodation and boundary making, effective communication, learning to solve problems together, being considerate of each other, and finding more time for fun. The solution-focused model is a descendant of the MRI approach that we talked about earlier in the term. But instead of focusing on what people are doing to maintain their problems, solution-focused therapists look for what clients have done to overcome or cope with their problems. Both models, the solution-focused and the MRI model, both models try to resolve the presenting complaint as quickly as possible. The MRI model does so by looking for solutions that don't work, while the solution-focused model looks for neglected solutions that do work. Instead of trying to understand the cause of problems, solution-focused therapists help clients shift their attention from their problems onto the things in their lives that are going well. This shift from failures to successes is thought to help people stop dwelling on negatives and rediscover positive solutions already in their repertoire. While critics have suggested that this switch from problem talk to solution talk is little more than a pep talk, the idea of reinforcing positive behavior has a useful impact on people's lives. The solution-focused approach draws many of its assumptions and techniques from the MRI strategic model, including the de-emphasis on history and underlying pathology, and a commitment to brief treatment. Solution-focused therapists only need to understand the nature of solutions that can apply across people, not the nature of problems that bring them into treatment. Also, like the MRI model, people are thought to be constrained by narrow views of their problems, which then generates rigid sequences of unsuccessful attempts at solutions. The solution-focused approach is different from the MRI model in several important ways. First, solution-focused therapists try to get clients to think exclusively about solutions that have worked or might work. Second, solution-focused therapists reject the idea of resistance and assume that clients really do want to change. They also believe that people are rather suggestible. No model of normal family development is suggested, and solution-focused practitioners believe that therapists shouldn't impose what they think is normal on clients. Solution-focused practitioners say that what's unacceptable behavior in one family is desirable in another, so it's clients, not therapists, who should identify the goals to be accomplished in treatment. Solution-focused therapists are interested only in the complaints clients present and in helping them re-examine the ways they describe themselves and their problems. They tend to assume that even troubled people are resilient and resourceful. Worrying about what causes problems is deliberately avoided in solution-focused therapy. Because solutions are seen as being unrelated to the ways that problems develop, problem talk and the related preoccupation with the cause of problems is seen as part of the reason people stay stuck in their dilemmas. Goals of therapy revolve around resolution of clients presenting complaints. The therapeutic atmosphere is one where people's strengths can be re-emphasized. Sometimes it's necessary to expand clients' use of their resources, and at other times, therapy may involve identifying abilities the client possessed but aren't currently using. Solution-focused therapists help clients define goals in small steps based on the assumption that small changes can initiate a positive spiral. Solution-focused therapists use a standard set of questions and tasks to create an optimistic frame of mind and to start a snowball of solutions rolling. Therapy is quite brief because the client and therapist orient their work in the direction of strengths, exceptions to problems, and clear goals and strategies. Early in the development of this approach, all clients were given the same assignment called Formula First Session Task. They were asked to observe what happens in their lives and relationships that they want to continue. This technique is used to help clients refocus from bad things in their lives to thinking about and expecting the good. And this shift in perspective is thought to build on itself. Solution-focused therapists avoid assessment of problems or how they develop. Instead, the focus is on how things can be better. The goal of assessment is to help clients shift their attention from what they don't want to what they do want. Scaling questions can be used to help define small steps that will lead in a positive direction. Solution-focused therapists don't feel the need to include the entire family. Instead, an attempt is made to identify the people most motivated to change and to work with these highly motivated members of the family. Therapy begins by helping clients define well-focused, positive goals and then generating solutions based on expectations. Therapy begins by helping clients define well-focused, positive goals and then generating solutions based on exceptions. Although therapists don't wish to dwell on problem talk, they make a point of listening to clients' descriptions of their problems at least long enough to make the client feel understood. Then the therapist helps clients develop concrete and manageable goals, phrased not just in terms of what will be happening, but in terms of How will you be doing this thing? 3 techniques are central to solution-focused therapy. Each functions to make problems appear less oppressive and more controllable. The exception question directs a client's attention to times in the past or present when they didn't have the problem. The therapist then explores with a client what was different about those times and tries to find clues to expand the number of exceptions to the problem. This is empowering because clients begin to see times when they were better able to control their lives. The miracle question is used to activate a problem-solving mindset by giving clients a clear vision of their goal in treatment. It also helps clients look beyond their problem to what the solution would look like. Scaling questions are used to identify concrete behavioral changes and goals and nurture small changes toward those treatment goals. Scaling questions are also used to ask clients to quantify their confidence in their solutions as a way of anticipating and disarming resistance and encouraging commitment to change. Some research has demonstrated that what makes solution-focused therapy unique, the refusal to talk about problems, turns out to be problematic. This has led to a call for greater collaboration with clients in order to first acknowledge and validate feelings before introducing solution-focused techniques.